Thank you for joining me today. In this video, you are going to learn for early onset of bipolar disorder. What are the symptoms to look for? Children and teenagers may have symptoms of bipolar disorder. So how are you going to assess them? How are you going to treat them? What the symptoms to look for? That is what we are going over here. That is what you're going to learn in this video. So, early onset of a bipolar disorder refer to bipolar 1 or bipolar 2 disorder with onset of a childhood and teenagers. It characterized by the episode of mood dysregulation with manic and hypomanic, often with depressive episodes. More severe courses that adult onset bipolar is a more severe course than the adult onset of a bipolar disorder. It higher comorbidity. It has a higher comorbidity. It increases suicidal risk. It is greater function impairment. So the children have a greater disability, functional impairment. So the DSM-5 treatment bipolar disorder relevant to the youth and children. Bipolar 1 disorder is at least one manic episode that lasts 1 week or greater, or any duration of a hospitalization requirement. Causes mark impairment, psychosis, or hospitalization. So if this episode causes it lasts 1 week and it has symptoms that require the teenager or the child to be hospitalized, that is how you diagnosed with bipolar 1. It also has to have a mark of impaired psychosis that needs to be hospitalized. Depressive episodes are common but not required for diagnosis. So it's 1 week or greater. Bipolar 1 is at least one manic episode that lasts 1 week or more and needs hospitalization or psychosis. Bipolar 2 disorder, at least one hypomanic episode plus one major depressive episode. No history of manic episode. Hypomania has to last 4 days or more. No marked impairment or psychosis. So bipolar 2 disorder don't have impairment or psychosis, but bipolar 1 has impairment and psychosis symptoms. Manic and hypomanic episode core symptoms include abnormal, elevated, extensive irritability mood, increased energy, or goal-directed activity. You will be motivated, you have energy, increased energy, and goal-directed activity. irritability mood is equal to 4 or more. It includes grandiolous decrease for sleep because your energy is high, you have a lot of energy, it's hard for the patient to sleep. They have a partial speech, they have a racing thoughts, they have distractibility, it's hard for them to concentrate. Increase goal directive, they want to do everything once and everything and all things. So they are impulsive, they are hypermanic, they have a lot of energy, active, laughing, doing all things. They conduct risky behavior like sexuality, expending, they spend all their money. They have aggression or irritability or agitation mood, and must represent a clear change from the baseline. So this is abnormal, it's not something normal. There's a people who have energy, people who have a goal oriented, people who are, but this is something abnormal that this person never had before. It has to be something new and more. Clinical presentation in children and teenagers is this is a severe irritability, explosive temper outbursts. They are yelling, they are crying, they are having outbursts. Their sleep is this, they have a sleep disturbance with minimum fatigue. They don't have fatigue, they are running around, yelling, outbursts, a lot of energy, rapid mood shifts, but still episode, not chronic, it's episode. Psychotic features, they have psychotic features are more common than the adult. They have high rates of ADHD, anxiety, and substance abuse. So mostly, not always, but children who have ADHD, anxiety, and substance abuse may go through this phase. So differential diagnosis include ADHD. So the child may have ADHD already. They may have depression, major diagnosis depression, chronic irritability. They may already had major depression. They may using substance, and this is substance induced. They may have trauma related disorders. So how to assist them, how to know and figure out what it is. Assessment include detailed longitude history. So you go and assist the past history, medical history, currently illness, medical and psychiatric illness. You want to establish a episode. When did this episode begin? Correlate from parents. You want to collaborate with parents and teachers. You want to review anti-psychiatric reactions for manic or mood swing. Assess suicidal ideation at a very at every visit. So treatment and interventions include core principles. Psychotherapy is the first line of treatment. Psychotherapy is added and adjusted but is essential. You can add pharmacology. So pharmacotherapy is the first line, but psychotherapy can be added to and it's essential. Pharmacology treatment include mood stabilizer. Lithium is FDA approved for ages 13 to 17. It reduces suicidal ideation and risk. Valproic is also mood stabilizer medication, and it's used youth over off-label use, has off-label use for teenagers. Carbamazepine has a less commonly used for teenagers. Second generation antipsychotic medication can be used. Strongly evidence for acute manic. Risperdal treat and can be used for approved age 10 to 17. Risperdal. Babrazal is age 10 to 17. Seroquel treat mood, manic, bipolar depression. Olanzapine or Cyprexa is used to treat acute manic. Azanabine is also used acute manic disorder. Fast onset, then the mood stabilizer. So the second generation antipsychotic medication are faster, they have a fast onset, then mood stabilizer. Antidepressant medication never as monotherapy. Antidepressant medication never use them as a monotherapy, may trigger manic episode. So it can make the manic episode more worse than it is or increase. It triggers manic swings. Only with mood stabilizer coverage. You can use only with mood stabilizer. Psychotherapy is added to the pharmacotherapy. Psychoeducation, you want to provide psychoeducation for the patient and family. Family focused therapy, you want to provide family focused therapy. Cognitive behavior therapy, interpersonal and social rhythm therapy, regulate sleep and daily routine. Acute safety interventions include hospitalization for a severe manic and patient who is having a psychosis. So hospitalization is recommended for patients who have psychosis, who have suicidal ideation, who have severe manic, who are more access to means of harming themselves or others, close medication monitor who need a more close monitoring. You want to monitor weight gain. Psychiatric medication is increased weight gain, so you want to assist the weight gain, BMI, metabolic labs. You want to assist lithium level, renal function, thyroid function. You want to assist the adhesiveness and high relapse risk for non-compliant. If they don't take their medication, they will have relapse risks. Ongoing assessment for self-harm behavior. Prognosis often is a chronic and relapsing, so it causes relapse. So it's chronic. They take their treatment, they get better, and then they relapse if they stop the medication or there is a trigger. Early onset is associated with more episode, worsen psychosocial outcome. The outcome improves with early diagnosis, consistent treatment. If they take consistently their medication, their mood will stabilize better. Family involvement improves the prognosis outcome or treatment outcome. You want to rule out ADHD hyperactivity. So mania is not equal to ADHD. So there is a ADHD hyperactivity and there is a mania. They are two different diagnoses. Bipolar disorder is an episode. Mood stabilizer or second generation antipsychotic medication are the first treatment, not SSRIs. SSRIs is not treatment for manic episode of bipolar. Lithium stabilizes the mood and reduces the risky behavior of suicidal ideation. ADHD depression, major depression disorder is not equal to bipolar disorder. Always reassess the diagnosis over time. So you want to reassess every time they visit. You want to assess if they're taking their medication, if the mood improved, if the functional improved, if the mood is stable. You want to assist the lab. You want to assist the side effects of the medication. You want to educate the family, the patient, the teachers, anybody who is caregiver to the teenager and the child. And you want to have confidentiality and consent. Thank you for joining me today, and I would love to see you in my next video. If you have these symptoms, please seek medical attention. Thank you.